Hi, everybody. I was telling my colleagues that I'm usually here for Stanford Medicine X, where there are balloons everywhere, so this is a little bit of a different setup. Let me make sure I have my slides. Okay. Let me go back here. All right. So about a year and a half ago, the president launched the Precision Medicine Initiative. And last year, in a rare act of congressional bipartisan support for the future, Congress funded NIH, fully funded NIH, and we have an extraordinarily strong bipartisan support for this work going forward. The goal is nothing short of daring: to enable a new era of medicine through research, technology, and policies that empower patients, researchers, and providers to work together towards tailored therapies and health. I'm not going to give the talk you expect today. I won't be talking about the updates that are outstanding around what steps we've taken since Congress funded this. Kathy and Bill are both here, Kathy Hudson and Bill Riley. They'll be talking about that. Instead, I want to talk about the emergent opportunity to truly unlock the power of big data for the vision the Dean described. And I want to talk about how we're trying to think about this work in PMI as a platform for that kind of innovation. Last night at a roundtable, we were chatting about I use the framework roses, thorns, and buds. What's a rose? What's really working? What's a thorn? What's really stopping us? And agreed remarkably with a group of technologists and data geeks around the table that the thorns are our own business rules. The thorns are our human silos. The thorns are not largely technology or data-driven. We know that even though we have this enormous universe of big data, any given researcher is working away at a little corner of that huge universe in their own place, and that if we are truly to enable this future, we need to find a way to create very different ways of working. How might we unlock the power of big data in a fundamental way? How might we, as Susannah Fox says, engage the network as our superpower? Stephen Johnson studies innovation, and one of his observations is that innovations often come from edges. The edges where different disciplines, the edges where different mindsets and people mill about and smash their ideas together and have a dialectic at those edges. And it's also interesting, he observes, that often different edges produce the same result at almost the same time, because it's what we've just discovered that enables the next step. I believe that a lot of the innovations we're seeing from within the patient innovation community are important edges. These are edges we must observe very closely, not just because we know we have to engage patients as part of the research process to make it better for us, but in fact because they are showing us the way forward. They may not be scaling what they're doing yet, but if we can take those important insights from the edge of patient innovation, I would argue we will make very rapid progress. The president seems to really get this. And he is every time I've had any encounter with him, I am surprised not by just his smartness, but by his understanding of the essential underlying forces at play in the changes we need to make. And so an issue on which he has been extremely forceful with us and very engaging is to say, let's allow that patient, that person, to be part of the solution. And in fact, when he launched the precision medicine effort in January of last year, the only group he met with was a group of patient innovators before the event, along with some of the leaders from within the government. One of those was Elena, shown in this picture. She's an undergrad at Harvard, I think she still is, who is taking time off with her brother to study her own rare cancer. We'll talk later about Matt Micht, who's pictured here as well. And so what the president asked us to do is, how might we build this effort in a way with those people, those patients, those participants as partners in equal standing as we move forward? So I'd like to knit these ideas together and paint a story of a few innovations that I feel are showing the edges that are possible with patients as innovators that we might be able to spread. What might that look like? A year ago, we convened a group of folks in Boston to ask this question: what could the future look like? And the ideas are interesting. What if we had a tax credit for data donation to research? What if we really engage citizen science in a fundamental way? What if in a year's time from then, that was June, okay, a little more than that, we're actually starting to see enrollment in the PMI cohort. We're starting to see people using the data. So these senses of urgency, of participation, of openness, were all very key to this future. Well, as the saying goes, the future is here, it's just poorly distributed. Let's take a glance at some of these innovations we're seeing that could spell the future for all of us. So I'd like to focus on a few problems, thorns, that we all know are keeping us back from the progress we want to make in research. And one of them is actually finding people to enroll in studies. So Matt Micht is a computer scientist. He's a geek. He also happens to have a son with a very rare genetic disorder. He didn't know that at first. He just knew his son was very sick. It took a long time to figure that out. But when he did find out what mutation his son had, unfortunately, his clinician said, here's the thing, we actually don't know any other patients who have this disorder. So you have nowhere to turn to ask, what's this going to look like 5 years from now? What might be some therapies? How do you deal with the seizures? Well, Matt's an enterprising computer scientist and a bit of a internet geek himself, and he said, I have the power of the world at my fingertips, and I know a thing or two about search engine optimization, so what if I created a blog post that was incredibly viral? And what if I used that to find my people? So his blog post included this picture below, and the title was, Help Me Find My Son's Killer. And he used search terms that he thought people with this condition would be looking for, the kinds of symptoms and also the exact mutation. And lo and behold, over the course of a fairly short period of time, he found 40 patients. 40 patients and their families. And they started coming together, they started talking, they started sharing notes, and pretty soon they invited researchers in. And pretty soon those researchers started getting interested because now there was a group of people to study, and now 2 pharma companies are investing in therapies for the future. So this man went from literally not having anywhere to go to think about the future of therapy to one where there's an actual cohort that he was able to find. And by the way, all of this information I'm presenting is either openly available on the internet or has been shared with permission with me by others. I know Mike O'Reilly is in the audience somewhere, works at Apple, has helped launch ResearchKit. And the promise of ResearchKit is to take the computer in our pocket and make it into a tool for participation. Because what else is hard? What is hard is enrolling in a research study. My mother was a PhD candidate herself. She spent 90% of her time trying to find people to enroll in her study. But what if from the platforms we use every single day, from the tools we use every day, it is possible to participate? So ResearchKit is an open source platform. Anyone can create a research app using the tools. Here are the results from one such study, mPower, which studies Parkinson's disease. 15,000 enrolled over the course of several months, 16% with Parkinson's. That's pretty remarkable. Almost 80% would like to share their data broadly. 93% had never participated in a research study. How might we make the computer in our pocket a tool for research participation. What else is hard? Getting EHR data into studies is hard. I cannot go 5 minutes in a roundtable without this coming up. And there are lots of concerns about how do we make the business processes better, and why is it that that data are locked up in the computers, right? We have a future that might be a lot different in that every single vendor, as part of meaningful use, will need to implement an API. An API like the others that are used across the internet to connect the services and tools that we use in a more seamless way. So what if you were a patient and you could donate your own EHR data to the research that you wanted to participate in using an API? We, working with NIH and ONC, have engaged 7 national vendors, Epic, Allscripts, Cerner, and others, Athenahealth, who have agreed to work together along with NIH and ONC to pilot what this could look like using the term Sync for Science. But could we build this in such a way that it would be deployable for all of your work so that people really could come into research with their data, at least with their EHR data? Here's another dad, Howard Look, also a technologist, was the CTO for Pixar, also has a daughter with type 1 diabetes. So when his daughter was diagnosed and was having challenges managing her condition, Howard, being the geek he is, sat down and tried to figure out how to bring the CGM data into a tool and how to do the app. None of it worked. And it, of course, didn't work, right? It wasn't meant to work together. And so he left behind his career working with these large technology companies to say, could we build an open source platform? Could we build a nonprofit, which is Tidepool, and then negotiate with all of these device manufacturers to share in a common way their data onto a platform that would then allow people to connect to their data? And we know getting this data, it's confusing and it's hard in research. So how might we build open source platforms to share both device data and other sorts of data that include agreement on the way we're going to do that? Don't go all the way to standardize every single thing all the time, but at least say, we will share in standardized ways, and that will enable research. You saw before that in the mPower study, 78% of the people participating wanted to share their data broadly. This is a similar pattern that we've seen in other examples of asking people about sharing, including 23andMe. People want to share. They want to share, they want to develop new cures. They want their data protected, but they want to share it. One of the things that's hard in research is the consenting process and the IRB process. And how do we make sure that we have an ethical construct that really works, that builds the future we want? And too often, I think people feel like we've ended up in this place where you have to have this sort of really narrow negotiation with the IRB in order to get your thing through, but you know the form doesn't really work for the people, right? So how could we reinvent this in a design-friendly way? So Synapse is a platform where a lot of the research kit data are going when patients say they want to share broadly. And Sage Bionetworks worked to say, could we develop a single sort of science ethics set of questions? Could we make sure that scientists are actually skilled and legitimate? And that doesn't mean that initials after your name or the organization you came from. Can we actually give them a skills test? So Howard Look would probably pass that test, as would most faculty, but it doesn't require that you be part of an institution. And then could we, in a very open, transparent way, have a set of guiding principles that people agree to, which include predictable things like I won't re-identify the data, I won't sell it for marketing, but also I will publish in open access journals. So you see through this kind of open, transparent desire to build out resources we can all use, if you build in the right business rules and communicate them clearly, that matches with those 78% of patients who say, share my data, please. Because what's offensive to many of them is that the data are locked in little traps and aren't shared because they have taken the time and energy to participate. Many of you know Patients Like Me, a platform for people with initially very serious conditions, now a broader range of conditions, to share their activities and their data, and have found that the observations people have at home provide extraordinary richness to research studies, which often can only capture a little ounce of data here and there as people come into the lab. So how might we move from a world of observations every 6 months to a world of observations on a daily basis? That's not just a question of the devices we put on people's bodies. It's a question of engaging these communities and these organizations where people are already gathered and talking. So I think our challenge is to not think of it as just a tracking device, but think of it as a way to engage that whole community. So we've talked about data and its observations, and I will say that one of the big challenges as you bring data together is understanding what the heck it means in relation to each other. We see this in health information exchange, where you have to spend 80% of your time matching data and bringing it together. Likewise for research, how does this tracking data mesh with the environmental data, mesh with the EHR data? That challenge can in part be resolved by thinking of people. Me, I am the context. Here's Katy McCurdy, who has had fairly serious health conditions that were also very complicated. Lots of different encounters, lots of different therapies over a period of time. She was spending every little minute of every doctor's visit simply explaining her history. And she said, we can do this better. I'm a designer. What if I showed this as a picture? And here's the picture she drew of her last year. And then here's the picture Doug Cantor drew of his year of diabetes data. So I think two insights here. One is this power of visualization and design, including from patients themselves, and also that the person themselves is context, and we have to find a way to embrace that in research. So now we have new ways of sharing, new ways of finding cohorts, new ways of thinking about data in context. And we saw Doug and Katy starting to ask really interesting questions about their own health. Doug said, goodness, interesting pattern of my activity and my insulin. Let me make a hypothesis about how I can change my activities, and let me see if that affects how much insulin I need. But what if we were able to actually bring researchers, patients, and clinicians together in that kind of campfire of data, where we're asking questions, hard questions. What does this mean? Why is this working the way it is? And that's what C3N at Cincinnati Children's has done. Michael is one of the architects of that. Erin is a patient leader of that work. And they've created an open platform where the data are shared across those three groups, and any one of those parties can ask questions of the data and have the team help them design a little N-of-1 trial to test it. So here's an example of Erin's son's data. Erin's son, Drew, has CF, and she was looking at antibiotics and cough. So she was recording his daily cough at home, and then observing the patterns on different antibiotics and asking questions of our clinicians. What if we try this other antibiotic that seemed to work last year? Now you might ask, that all sounds awesome, but it's hard enough for us to bring together just the basic pieces of research. People are not participating. People are dropping out of our studies. But I would argue if we cannot find a way to engage this excitement and this iteration and this delight, we will not make the progress towards big data that we want to. This is the hypothesis that Anna McCollister-Slipp has, working with Scripps on Vital Crowd. Could we actually, in an organized way, bring patients in, participants in, early to the design of scientific interventions to ask, what questions are most important to me? What methods will you use to collect them? And how does this actually work for my daily life? Guess what? I don't want to come have my blood drawn at your clinic every 5 minutes. It's not going to work for me. So could we actually imagine how might we build out in all of our work in big data this concept of a much deeper collaboration at the front end and throughout the process. Tim O'Reilly coined the term, I believe, government as platform, and also government 2.0. And I think the underlying idea is that we, through our actions, through our investments, through our policies, can enable a different future, not just through the specific concrete things we're doing, but also by showing the future that's possible. So one thing would be, could we actually imagine some kind of shared data commons that would actually enable all of your work, that would take these various threads of openness and innovation and patient engagement into account? And Kathy and Bill will talk later about PMI, but these are a couple slides from the advisory group that recommended the way to build this out. And imagining the Precision Medicine Initiative cohort, the 1 million people that will eventually be enrolled, as a sort of data commons that with the right protections and with the right permissions would be available to a vast array of researchers and might pull together all of these threads of data that are currently in silos. And that also would include an architecture of participation where information would flow back to participants. Many of you are pioneering ways to do this, and we need to work together to figure out. So open data for researchers, having that go back to participants so they too can build out this ecosystem over time. If we're thinking about government as platform, what if patients could easily assemble their own digital data and donate it for research? This has been an idea I've been really excited about for some time. I am seeing it bubbling up many, many different places. How could government serve as a platform for that future? Well, one thing is, over the last 2 terms of this administration, we've gone from very low penetration of EHRs in many places to almost universal. Digital data for almost every American. I know it's hard. I know it's not perfect. But we have coded digital data for almost every American now. That is extraordinary. But we know it's really hard to get. But could we somehow leverage this amazing ability that patients have through HIPAA, which is a valve, not a blockage for patients' access? I have a right to my digital data. I have a right to my data in the form and format I want. I can ask that it be emailed to me, and I can ask that it be emailed to somebody else, including a researcher. So can we put these pieces together, these pieces of government as platform, and take this future at the edges that patients are demonstrating through these extraordinary innovations and actually create this kind of ecosystem that we want? This is from our event in February to announce the latest amazing accomplishments of PMI. You'll see Howard Look there from Tidepool and the president, and Sonia Valab from the Broad Institute. And the president in passing said, and he said this very carefully, he said, I know there are a lot of legal things to be worked out, but don't you think that if somebody does a test on me, then that information should be mine? So this concept of patients as stewards and owners and curators of their data, okay, maybe they don't want to spend a lot of time on that, but couldn't we unlock so much possibility if that really existed, tapping into this HIPAA right, tapping into the digital data and this extraordinary motivation of patients? So my ask of you, let's join together. Let's make it easier for patients to access, understand, and share their health data. And that means you. If you're a researcher, how might you do that? If you're a delivery system, how could you actually debug the extraordinary friction that exists today on people getting their own data? How might we create and scale models for participants to be partners in research? We heard from the dean to talk about Stanford's involvement in ResearchKit. These cannot be edge cases any longer. We have to make this central to the way we operate in the future. And most perhaps importantly, how can we build an open innovation ecosystem for data? There are a lot of disincentives for this that I understand. But if our future is going to be one of big data, I would argue we need open innovation, we need participants as partners in research, and we need to decrease the friction to allow data to flow where patients want, including to research. So thank you so much for your time. I am so excited that Kathy and Bill will be talking more specifically about PMI, but it's been a delight to talk with you, and I will stay on stage for Ewan. Where do you want to go? Okay, great.
Well, Claudia, thank you so much. That was really a wonderful presentation and really covered a number of areas that I think we could talk about now in the discussion. I'll say just before we get started, if you haven't downloaded the app for the meeting, you can do that now by going to the App Store and typing in Stanford Big Data, and you can download it. And there's actually a method in there for directing questions to us on stage. If you don't want to, alternatively, you can do the usual thing and do it in person and put your hand up, and we have some roving mics that can take you there. But I'd like to start off while you're thinking of some questions, just to chat a little bit, and to follow up some of the themes we were able to chat about a little at the roundtable yesterday. You gave us some very inspiring stories of computer scientists and others very motivated to be part of their healthcare. We talked about the extent to which that applies to everyone, and whether there were people out there who really weren't that invested in their healthcare or were busy doing other things in their life. And I wondered if you could comment a little bit on that. Is this something for a small minority of very tech-savvy people, or is it really something for everyone?
It's a great question. You know, one of the things Susannah Fox has taught me, and if you don't know her, she's an amazing futurist, I would say, about people and digital data and technology, is that these alpha cases, I think of them as patients that often have very difficult health challenges, can be very instructive for what might be possible for all of us if we put together the right platforms and the right structures. I think actually ResearchKit is a good example of that. If it's as easy as literally picking up your phone. So last night at dinner, one of our colleagues was able to load his 23andMe data into his participation in ResearchKit. Literally took what, 30 seconds?
30 seconds.
30 seconds. So if we think about all the friction points in participating in the ways we've described and really brought them down as much as possible, my belief is that these alpha patients are simply showing us the path that would be possible for all of us. That said, I go to a provider that has a health portal, and I've looked at it once. And that's because I'm really healthy. I've been to the doctor maybe once in 3 years. So I think it's true that for a lot of us, if it's as easy as pressing a button, we'll do it. But don't ask me to go in and ask questions I could care less, right? So we have to think about those different clusters of patients, but yet I think the friction is enormous to do these things today.
Yeah. Well, and I want to make sure I ask you the question that I think is on the tip of everyone's tongue, and we don't often have this opportunity to have someone from the White House here, but how safe are the Precision Medicine Initiative and the Cancer Moonshot from, let's say, a future administration? We don't need to go into what that administration might be, but just in terms of a transition to a new administration, and these ideas being, you talked about how personally Obama is invested in the Precision Medicine Initiative. We know how personally the Vice President is invested in Cancer Moonshot, but of course both of them are out of a job in 6 months' time.
As am I, Sophia.
Okay. So what happens next?
Good question. And I would also invite you to ask this of our colleagues from NIH. A few things. One is this area has extraordinary bipartisan support, more than just about any other. I can think of some topics where there's support on the negative side. This is one of those rare topics where there's support on the positive side, with Congress giving substantial additional funding beyond what the president asked for to NIH this year. So I think we will continue to see extraordinarily strong bipartisan support. Also, NIH has done an amazing job in embedding this work and getting it going and making it robust. Eric Dishman will be joining shortly as the director. And so it'll be off to such a wonderful start by the time this administration ends. But also remember that NIH is a team of scientific leaders and executors. All but just a couple stay when the administration changes. So with funding from Congress, with this great start that has been, the tracks that have been laid down, and real stability of leadership, I have every confidence that it will continue robustly.
Yeah, thank you. Now we can take some questions from the floor, so please feel free to, we have one just here.
Thank you.
And if you could introduce yourself first. that would be great.
Hi, my name's Marilyn Ritchie. I'm at Geisinger Health System. Thank you for that inspiring talk this morning. It was really wonderful. And actually, when you just answered Ewan's question, it made me think even more about, I think we're seeing patients that are very engaged who have health conditions or whose family members have that. But as we think more and more about precision health, what we also want are all of those healthy people to contribute their data and be really motivated. So I'm wondering what the conversations have been around engaging those healthy individuals so that we do get the data. And I think your point about being able to contribute it passively is going to be very important. I know when we've surveyed our patients, they don't want to have to do too much. If they have to push a button, they would do it. So I'm just wondering what other incentives or motivations people have been talking about to incentivize the healthy to also contribute all of these data.
It's a great question. I think one connection often is through loved ones. We all have loved ones with Alzheimer's, cancer, cardiac disease, other conditions, and we're very motivated to make sure that there are good therapies and outcomes for them. I think another is that people are innately curious about themselves. So if we can find a way to sort of like feed information back in a way that's a little contextualized around here you are, here's the rest of the world, that is very enticing to all of us. We all want to know where we stand. We want to know how many likes we got. We want to know what our community is looking like. That's a different way of operating, but I think it's very enticing. I also think, and this is a bit further down the line because I don't think we yet have good tools for this, but think of all those really crappy things you have to do in healthcare, from signing up for a health plan to like that crappy immunization record you need for your kids' camp. And if we could find a way to deploy the collections of data we do for research to help people with tasks like that, I think that could be really, really helpful. I also think again, I don't go to the doctor very much, but I don't find my conversations about health, like I spend quite a bit of time thinking about nutrition and exercise. None of that conversation happens with my primary care physician. And if I could have actually meaningful tools to help me with some of those key decisions, I think that would be, again, very engaging. But I think the reality is we have to, if you think about the idea of behavior change as being motivation, reducing friction, and feedback loops, we focus a lot on the motivation. We don't focus as much on the feedback loops and reducing friction, and I think most of our progress is probably going to lie there.
Just on that topic, there was quite a lot of interest on Twitter as you were speaking regarding the both carrot and stick aspect of, you'd mentioned about the healthcare providers, the EMR providers, committing to producing an API so that data could be sucked out by an app, for example, and being made mobile. This was perhaps one of the original visions of HIPAA, which is ironic, of course. Could you say a little bit more about that?
About the API?
Yeah, and that commitment that you have.
Yeah, sure. Well, I'm not going to do a long treatise on meaningful use, which has its lovers and its haters. But I think what's really amazing about our accomplishments on that side is that we do have a single set of things that we expect all vendors to be able to do. And while it's not always as easy or pretty as we might like, the fact that we now have coded data on the core data set, the fact that every EHR can record smoking status and things like that, the fact that every EHR gives patients ability to access their data are extraordinary platforms. So now if we think about every EHR vendor having to provide an API, that's something that they're going to have to do by regulation if they want to get certified for meaningful use, which all of them will. But what we're asking them to do is implement that ahead of time and in a way that really enables this use case around data donation. I have been on the phone with every single one of those CEOs, and they are very excited about this. And the thing that now NIH and ONC are working on is how to make that a real commitment that delivers actual data flows over several months. And that's where things do get more challenging. So I think we're continuing to try to engage those vendors and keep them excited. They see this, though, as a potential real business value for themselves. So I'm really, really excited about this. I think it's going to be like when the patient shows up with their app to their provider and says, connect my API to this. We talked about this yesterday. We don't yet have a way to think about that, right? And I am certain that every one of your security officers would say no, even though HIPAA says yes. So we have a lot of work to do to figure out what that looks like. How does a patient actually bring an app into connection with an API that has their own data? And we need to figure that out pretty rapidly.
And you mentioned something that I think is not so widely known, that HIPAA actually contains the requirement that the data must be in the form that the patient asks for it, which is something that I think is not so widely known. But could be transformative if we were to spread that word a little bit more.
Right. So, your EHR has all your lab data in LOINC, so you can ask. I mean, you wouldn't want this necessarily for daily consumption, but if you're participating in a research study and you say, I want all my LOINC data, the vendor can't, or the provider can't easily say, well, we don't have that. Yes, they have it. It's in their EHR, right? So you are allowed to ask for data in the form and format you want. The provider cannot, that has to be able to deliver that if it's something that they can do, but they should be able to do all of the stuff that they're required to do by certification. So I think we need to start to really put these pieces together in a more meaningful way so that you actually could show up and say, send me my API with all my coded data for the last year to X researcher who I'm super excited to be working with. Wouldn't that be amazing? We're a little ways from that, but I'm hopeful.
That would be amazing. Yeah. We could take another question from the floor if there is one. Just at the front here.
Thank you for that inspiring talk. Eleni Linas from UCSF. Big data and precision health is inspiring, but at the same time, there's a parallel movement and concern among physicians and patients of overdiagnosis, over-testing, over-treatment, and a movement towards less is more. How does that approach fit with the big data and precision medicine initiative?
Interesting question. Let me give you a little mini story from Erin, who you met earlier. So Erin showed up with her kid at an ER, and they said, we are admitting your child, and we're giving them IV antibiotics. And she said, whoa, hold on a minute. I know my kid's baseline, and I know his reaction to these various meds. And she actually had a printout of the data. She said, so I think here's where we are, and in the past, she's a pretty, that's not everyone's going to be able to do that. But I actually think big data is as powerful in informing not doing something as it is in informing doing something. She was finally able to persuade them not to put her kid on IV drip and not to admit him. So I think we are not as motivated to think in those ways, but certainly folks in the geriatrics community, they're looking at over-medication and people literally losing functioning because they're over-medicated. I think if we that would be an extremely interesting use case to start to look at if we applied big data to med management in that population, what kinds of insights and solutions would we come up with?
Well, I'm going to use the chair's prerogative to ask the last question. You've been working in this area for quite some time. I had the joy of looking through your biography, of course, in being the moderator this morning. You mentioned in 6 months you're out of a job as well. So what's next for Claudia Wilson? Where are we going to see you?
I don't know. I really feel like we are at the edge of something extraordinary where this patient voice comes together with data, and also something we didn't focus on today, new delivery systems and new payment approaches. One little example, Iora Healthcare is a primary care innovator who huddles every morning with their 10 community health workers, one social worker and one doc, to assign a worry score to every patient who they're seeing that day. And so so these are the things that are exciting me, is if we think about these really different ways of delivering care and this vast potential of data and then this energy of patients, how can you put those together to actually create new business models that are transformative? So that, I don't know the answer to your question. Mostly I want to take a vacation, but if you have ideas for vacations,
yeah,
let
I
me
have
know.
some of those too.
But thank you so much. This has been so much fun.
Yeah. Please join me in thanking Claudia Williams.